And I am thrilled to be here with you. Ralph, thank you for the invitation. And always good to see some of my Tennessee colleagues out and about. A couple of moments on where we have been and some of the lessons that we wish the president would have taken from Tennessee when he was looking at Obamacare. Bear in mind, it was March the 23rd last year when he signed PPACA, or PPACA, however they want to say it, the Patient Protection and Affordable Care Act. That is the given name of Obamacare. And of course, we have come to realize how oxymoronic that name really is because of all of the mandates that it is heaping on our physicians and our hospitals and our providers and our employers and employees and small business owners. As if Lee's regulations that she was speaking of are not enough, guess what? Obamacare is going to bring you 3,423 new ones. It is going to cost, starting next year, $569 billion of new taxes, and they have robbed the Medicare Trust Fund of nearly $600 billion in order to stand this program up. So that is the regulatory and financial picture that is there. So let's look at TennCare, because TennCare really was that first public option trial that was out there, and in '94 they needed a place to try out Hillary Care. So Tennessee was the lucky winner of that. The objective of TennCare was to use anticipated savings from Medicaid to fund and expand coverage to children and the uninsured. We know that that never happened because the lesson there was that quality went to the lowest common denominator and the program collapsed under its weight. And there is a lesson in here. Anytime you bank on increased expenses on the front end to give you a huge savings on the back end, guess what happens? You never get it. You never get it. And that is what happened. Now, the parallels that are there are public option plan designed to save money and expand coverage. The outcome for TennCare in '98, TennCare grew. By 1998, they went from 94 to 98. By 98, there were 1.2 million people on the TennCare rolls. And the governor called for new taxes, called for setting up a completely new state income tax system to pay for what was then categorized as the unforeseen cost. The unforeseen cost of TennCare, and I know Ben remembers all of these carefully chosen words very well. Now, by 2002, the enrollment had grown to 1.4 million people. Then it got to nearly 1.5 million people in 05 and 06. Governor Bredesen decided that he was going to reshape TennCare and remove nearly 200,000 people off the rolls. And TennCare's lessons should have challenged the Obama administration on thinking on the benefits about public option health care. And repeatedly, in hearing after hearing, I would question Secretary Sebelius. Madam Secretary, could you please cite for me what is the public option model that you are using? Can you tell me where a public option plan has been successful? Can you cite for me where one has saved money? Can you cite for me where a public option has increased access? Can you tell me where one has increased quality of care? Crickets. I'm still waiting for the answers. Because there's not one. And I've made certain that I've asked my questions repeatedly of her on the record. Well, let me tell you what some of the lessons that we have taken from TennCare and have questions that we have asked about Obamacare, and I want you to be asking these questions also. First lesson that May and Judd and some of us learned is that free health care is mighty expensive. Amazing how common sense works, isn't it? You know, when you incentivize use, when you have a gold-plated plan like TennCare was, then what you have is paying the top dollar. Because TennCare paid for every doctor's appointment, every prescription. You and I have all heard all the stories of people that chose to charge the taxpayer hundreds of dollars for a cold rather than going to the pharmacy and paying $5 for an over-the-counter item that would have addressed that cold. So while TennCare, which was to be free care, anticipated those savings that were going to expand that care, they also estimated that what you were going to have was a program that would run after it was fully funded, fully ramped up, was going to be $2.5 billion a year. Now, by the time they got to 2005, it was $8 billion a year and 35.3% of Tennessee's budget. Think about that. Think about that. So free is mighty expensive. Next thing, some employers prefer free care to private care. And this we found when we looked at how the rolls had expanded in the state and looking at this free option of public care and how it added to the state's cost. The analysis of the TennCare rolls showed that 55% of those added to TennCare came from the uninsured population. 55%. The balance of that number came from those that had previously had private insurance and moved from the private insurance market to the public rolls. ObamaCare erroneously thought that they were going to be able to solve this by forcing employers to offer insurance to their employees with the employer mandate or pay a $2,000 per employee fine. Employers across the country are telling us that rather than keep their employees on private insurance, they're probably going to opt to pay the penalty and put their employees into the state exchanges that are slated to come online in 2014 because of Obamacare's essential benefits mandates. The federal government now dictates what employer-based health insurance plans must provide. As we predicted, this will lead to skyrocketing costs for benefits, and we're already seeing insurance costs escalate, leaving employers with a simple economic decision to make. Of course, the people behind Obamacare saw this coming. Their goal is to force all Americans into their exchanges in an attempt to centralize and control each individual's health care options. Lesson number 3, there is a distinct difference between access to the queue and access to care. Government-run healthcare advocates overpromised on benefits to gain support for their plan, but we have seen them renege on those promises now that the bill has become law. It is a classic bait and switch. To pay the TennCare bill, benefits were slashed and reimbursement rates for doctors and hospitals were reduced. Since they weren't being paid, fewer physicians could afford to accept TennCare patients. So while the TennCare card guaranteed access to the queue, it did not guarantee the availability of care. I think we're going to see the same thing in Obamacare. Physicians will see a boom in patients on Medicare and Medicaid. However, to pay for increasing these programs from available funds, they will say, Payments to providers must be delayed or cut. And you all know that Medicaid pays less than Medicare, which pays you less than private insurance. And on the current trajectory, Medicare will soon pay you less than Medicaid. Medicare's method for paying physicians is completely dysfunctional. Unfortunately, ObamaCare failed to do anything about it. Instead, it will continue to burden this system, and you're going to see patients and regulations falling through the cracks while physicians are not paid for the care for our Medicare. Medicare payments to physicians are slated to be cut nearly 30% at the end of the year, and it is well past time for Congress to address the issue of the sustainable growth rate and the formula that is there to fix it. So at Energy and Commerce, we are continuing to push to get this addressed, because right now, by not addressing it, by kicking the can down the road, guess what? There is a $298 billion hole in making certain that physicians are paid. Next lesson. Government control puts more people in the exam room than you and your doctor. You've always got the invisible and the unseen. And in our technological world, Twyla, I refer to it as the avatar, the bureaucratic avatar, always in the exam room, because government health care can only provide what it can afford. A determination of cost-effective care becomes more important than doctor-recommended care. How many times are you hearing this now? Cost-effective care. Doctors become intermediaries between the government and patients, only able to offer suggestions on their treatment. In Tennessee, physicians often spent more time arguing with government and insurance bureaucrats over care than they did providing the care to their patients. Now, all of this sounds a lot like the IPAB, Independent Payment Advisory Board, that is a part of ObamaCare. And as you know, the board of unelected bureaucrats is one of the central pieces of ObamaCare. The president believes the only way to truly control health care costs is to have bureaucrats making health care decisions, not patients and their physicians. This rationing board will cut payments to health care providers, cut services available to seniors, and firmly insert a bureaucrat directly between you, the physician, or you, the patient. Fortunately, my Tennessee colleague and Congressman from the 1st District, Dr. Phil Rowe, has introduced bipartisan legislation to repeal this band of bureaucratic rationers. It is H.R. 452. It's the Medicare Decisions Accountability Act of 2011, and it would repeal IPAB. We brought HHS Secretary Sebelius into Energy and Commerce to discuss IPAB and H.R. 452, and based on that hearing, our suspicions and our fears of the potential this board the harm that they could do was confirmed. Dr. Rowe's bill now has nearly 200 co-sponsors, and we hope to get it to the floor of the House this fall. As you know, one of the first acts taken by the Republican-controlled House in the 112th Congress was to repeal President Obama's health care bill. On January 19th, we passed H.R. 2, and we called it the Repealing the Job-Killing Health Care Law Act. And it completely repeals PAPACA or ObamaCare, effective as of its enactment, and restores provisions of the law amended by the ObamaCare Act. Aside from containing provisions that are potentially unconstitutional, creating a board to ration care for seniors, and heaping numerous new burdens on those like you who provide health care services, if not repealed, PAPACA would result in, and this is their estimate, $2.6 trillion in new government spending. Bear in mind, it's taking $1 trillion to stand this up. Now, what is going to happen if what happened to TennCare, which was to be $2.5 billion and ended up $8 billion, If that happens to Obamacare and they're that far off in their estimates, and that 2.6 trillion becomes 8 or 9 trillion within a decade. Do you see why we're trying to get this off the books? It is a program that is too expensive to afford. We cannot afford it. We all agree that our health care system and the delivery system and the insurance system need reforms, and that is why Republicans have pledged to replace individual portions of the Obamacare law. To that end, I have introduced the Health Care Choice Act of 2011. It's H.R. 371, and it will be one of the first of many efforts to replace the bill. It offers true market reform and addresses the high cost of health care and the difficulties individuals have in obtaining health insurance. If passed, this legislation will repeal the mandated insurance provisions in PPACA, including the individual and the employer mandate. My legislation completely repeals Title I of Obamacare. That is all of the insurance provisions. And it subsequently amends the Public Health Service Act to provide for cooperative governing of individual health insurance coverage offered in interstate commerce. In short, H.R. 371 will remove the artificial barriers that are created by state lines, allowing consumers to purchase health insurance that best meets their needs from any insurer in any state. For the first time in the health insurance marketplace, insurers would be able to compete for your business. And you could choose a plan from wherever that you could get it. And I'm grateful for the support that AAPS has provided for the legislation, and I am really looking forward to having their help this fall as we move this bill to the floor in September. Obamacare also failed to address another critical aspect of health reform that is badly needed: medical liability reform. However, another colleague in the House, another of our physicians, Dr. Phil Gingrey from Georgia, has introduced H.R. 5, Help Efficient, Accessible, Low-Cost, Timely Health Care. It's called the Health Act. It's a bipartisan bill. It would fix the broken medical liability system by removing trial lawyers from the health care delivery system. What a novel concept! H.R. 5 would limit attorney contingency fees. It would set a 3-year statute of limitations after the proof of injury and caps non-economic damages at $250,000. These reforms are vitally necessary to protect physicians from having to practice defensive medicine. These are just a few of the issues that we are working on in Congress. My colleagues and I are continuing to make certain that we keep the focus on how do we secure available and affordable health care for American families. Our nation must move from today's bureaucracy-driven, heavily regulated healthcare system to a new patient-centered system of consumer choice and free market competition. And as long as I'm in Congress, I'm going to continue to fight for that, to fight for our families, and to make certain that we keep the focus on accessible, affordable, quality health care. Thank you so much for the time today.